Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady Rahban, and we have part two of a two-part series. I think one of my favorite episode series we've ever had, because I think what it does is we're highlighting the things that you guys don't realize happen in the OR. And for me, it's the underbelly of everything that I've done for 20 years. For 20 years, I've tried my very best to educate patients and prospective patients on what to do and what not to do to have a safe and successful journey in plastic surgery. And I've always tried to highlight where you're going to get in trouble. And we are so lucky to have Paula, our nurse practitioner, here with us, because Paula has an experience that even I don't have, in that at the end of the day, everything I've shared with the listeners and the patients have been my own experiences. But because Paula has her own vast experience in the operating room with so many different surgeons in so many different environments, that we get a glimpse of what's happening. And it's just basically echoing what I've said for years, but with its very specific details. So thank you, Paula, for coming on the show. We did the first series, and the series was talking about what I refer to as OR nightmares. And this is just the second half. We just had so much to talk about that we didn't have a chance to wrap it all into one episode. Number one, just for you who, if you haven't heard the first episode, stop this one and go listen to the first episode, because I think it's very, very important information. But for those of you who are just listening for the first time, Paula, you've been a nurse now for 6+ years, right? And you've recently joined our team, and we're really happy to have you. But prior to being with us, Paula was a highly desired OR nurse in the Beverly Hills area with super prominent plastic surgeons. Obviously, all of these things are going to remain anonymous, but you know, people assume that when they watch the news and they see these catastrophic things that they're like, oh my God, what do you mean? I said this example in the last time, which is a doctor stuck his penis in a patient's mouth. Like, what? You think that happens in some random place in the country. But no, these things happen in the highest of highest echelons, which the average patient thinks like Beverly Hills is the Mecca, right? I mean, it doesn't get any better than that. And board certified plastic surgeons, it doesn't get any better than that. I can't go wrong, right? No, you can go wrong. And so I think Paula's insight and willingness to share these stories are really important for you guys that are listening, because you're otherwise not going to know this. So we ended the last series, and now we're going to pick up. And let's start with some really basic things, like when you're in an operating room environment, you have an OR nurse, a tech, an anesthesiologist, and a surgeon for the most part. And really, in my opinion, and I said this last time, is I think the surgeon is the one that really needs to make sure everything is above bar. We set the bar. If the surgeon drops the bar, then everyone is going to come to that lowest common denominator. But every once in a while, you're in a situation, and this is why I think one of the reasons why Paula chose to be with us, I hope. This is when you chime. This is when you chime in, Paula.
I just got kind of tired of going to like a bunch of different places, and the surgeon does things this way and this one does this way, and I just saw all the bad things that happen. And then I worked with you, and I was like, okay, he actually runs things efficiently, and the team is great, and he does everything by the book. And I just got tired of going to a bunch of different places and learning all the styles. So,
and also it also puts you in a compromised place. Every time you show up in a new facility and things are run sort of not the way you would run them, you have a license, you have a nursing license, you are exposed. If something is done illegal and you happen to be there, you'll get roped into it, right? Even though you're like, wait, I didn't have anything to do with this. It's not my fault, the doctor did it. Yeah, but you're in it. So it does make sense that you want to sort of separate and distance yourself, aside from the fact that it's the wrong thing to do. And I think what we talked about is there are many instances where you were like, oh, wow, this is wrong. I'm not staying. I'm going to get the hell out of here. So what were some of the things? And then you're the one who has to take the stand. So one of them was, I think you had told me something about a pregnancy test.
Yeah.
Yeah. So tell me a little about that story and what ended up happening.
Yeah, it was a surgeon I worked with for a couple months, starting to like it there, get the flow of things. And the morning of surgery, it's standard that we do a pregnancy test on all the patients up to like age 60. around there.
And why is that?
You can't do elective surgery on a pregnant person.
Right.
You don't need your breast when you're pregnant. So.
Right. It's because it is possible that the anesthesia, and you don't know you're pregnant, right? Mm-hmm. Because we check your pregnancy by lab, but by the time you get to the surgery, you could have gotten pregnant.
Yep.
So we do a urine test because maybe you don't know you're pregnant, and then we give you anesthesia, and God forbid you have a deformed child.
Right, exactly. So it was just another day. I did the pregnancy test and it was positive, and I did it again and it was positive.
You're
and
like,
I was like, okay,
oh shit,
yeah,
because it's positive it's a big problem. We gotta cancel the case. Like, hey, so sorry, I don't know what happened since you came, because your lab should have been negative, but that means that from the lab till now, whatever period of time is, you got pregnant.
Yeah, so the labs were negative, but they were done about 3 weeks prior to her surgery day. So I called the surgeon right away and I'm like, hey, like, sorry, because he was on the way there. He wasn't there yet. He was like, I'm like, the pregnancy test positive, and this patient was like 40. And she was still getting her menstrual cycle, and very possible that she's pregnant. And he was like, okay, we'll discuss it when I'm there. He gets there. He's like, let me talk to the patient. He goes to talk to her, and he's like, yeah, she told me there's no way she could possibly be pregnant. It's just a false test. We're moving forward. And I'm like, what do you mean? Like, she still gets her menstrual cycle. I'm sure, sexually active. Like, there's a huge chance. And she was just there for like a breast augmentation and lift. I tell the anesthesiologist, and the anesthesiologist like, let me talk to the surgeon. And he talks to the surgeon. They're both like, we're going through the case. She said that there's no way she could be pregnant. And I'm like, what do you mean? She said, like, she doesn't know. And so they're both trying to convince me to move forward with it. And I'm like, it's my name, it's my license. It's also just so unethical to be doing this.
Right. And I guarantee you, the thing that they're falling back on is that the patient said it's okay. Mm-hmm. So let me phrase this for you in a context you can understand. If I ask my son, hey, is it okay with you that you never go to school again? And he says, yeah. And I say, well, my kid never went to school because my son said it was okay with him. Is that okay? You asking the patient if it's okay for them to do something that we know that is medically unindicated is not a clearance. You don't get away with it because the patient said it's okay. You have a responsibility, not to mention the patient is compromised. Mm-hmm. They want something. They spent money to be there that day. It's a real inconvenience. So you could see them being like, fuck it, let's just go with it. And then what happens if she ends up giving birth and the baby's abnormal?
Well, that was the whole thing. The pregnancy tests that we usually do are the ones with the lines. So he's like, oh, the line's faint. I don't see a line. And then I don't see it. I'm like, it's right there. So I even went down to the pharmacy. I got one of the tests that say, like, positive, negative, exactly. And it was positive. I even got 2, positive. And I was like, I'm not doing this case. I'm going home. Like, you guys can find another nurse. I don't know any other nurses who would do this because we're the ones who sign off on the pregnancy test.
Right, because at the end, you know as well as I do.
Yeah.
Fast forward 9 months, she has not a healthy child. She decides to have a child. Oh my God, I was pregnant, and the child is not normal. Mm-hmm. And who is going to take the hit?
I mean, me, I'm the one who ran the test. Yeah.
100%. They're going to be like, we didn't know. Mm-hmm. The nurse told us it was normal.
Mm-hmm. Yeah. And so they were just trying to like, kind of almost bully me into doing the case. She said there's no way, there's something else, blah, blah, blah. And I'm like, well, why doesn't she go figure out why should we be having a positive test and then come back next month?
It's elective. She's not hemorrhaging.
Yeah.
She doesn't have a tumor that's eroding into her aorta.
Yep.
She's literally having a breast aug. Like,
exactly.
No urgency.
Mm-hmm.
So I think that's a really big deal. Mm-hmm. And I think this happens all the time. And what happens is, again, when the surgeon has his or her mind set to doing the case, they will make sure that everyone toes the line, whether that's the anesthesiologist who doesn't want to do it the way they wanted, whether it's the tech or the nurse. And more times than not, everyone's just going to go ahead and just be like, okay, because number one, they're usually the senior person. They're very aggressive. Mm-hmm. And number two, you need the job, right? The tech needs a job. The anesthesiologist needs a job. The nurse wants the job. So you guys are sort of in a very compromised position. So it's very unusual for a nurse to be like, I'm so sorry. I'm going to get the hell out of here. So bravo to you. Then we have another problem. You were telling me that there were cases that you had heard about or seen where you would do a massive surgery. Mm-hmm. We're talking BBL, 360 lipo, tummy tuck, breast aug, this rhino facelift, and the patient essentially had no workup, and then they're discharged like without much discharge instructions, and they're sent home to their family members.
Yeah, I mean, there's a lot of patients that I meet the morning of that I've worked with surgeons and I'm going over their discharge instructions. And for example, they'd get a tummy tuck. I'd be like, okay, just make sure you're in XYZ positioning after surgery. And they're like, what do you mean? No one ever told me that. No one told me I have to do that. And I'm like, this is basic stuff.
What
No,
do you mean you didn't get that? No one
yeah.
told you from
I'm
the
like, you're
office?
gonna have a drain. This is how you empty your drain. They're like, no one told me I'm gonna have a drain. And I was never on the clinic side of things with these doctors. So I was just like, how did no one go over this stuff with you? So they're being discharged with just extremely like false expectations, and I'm going over everything with them, and they'll have, like you said, all these huge surgeries where there's a million complications that happen where they should be going to like an aftercare or something like we send our
Right.
patients to, and they just send them home with like their sister who has no medical knowledge about anything like at all, which is just
Right. And that's,
yeah.
if there's ever a recipe for a disaster,
Mm-hmm.
it's to do this massive surgery, don't tell the patient any instructions, and then just hand them off to somebody who knows nothing about healthcare. It's like, what are you talking about? How is this even okay? We, on our side, and now you're part of it, we have a huge pre-op process. I mean, there must be 100 pages there that we go through, we highlight, they sign. Then we remind them the day of the surgery by the nursing staff, which happens to be you. Then they're always discharged to someone that's knowledgeable if it's a family member. And if it's a long case, they don't have a say. They have to go to an aftercare for 24 hours because God forbid something happens immediately. They need to be in some environment where at least somebody has a clue what's going on. So that kind of environment, and why do you think that is?
I mean, I think a lot of surgeons, because again, this is plastic surgery, it's mostly all elective. So I think a lot of people try to not treat it as like serious surgery. But then we're doing these huge cases. We're doing 360 body lifts, things like that. And surgeons try to play it off as, oh, it's, it's light, it's easy, it's an easy recovery. Because if we don't tell them all the risks that are associated with it or the complications that could happen if you do X, Y, and Z, then the patient's likely to not book
100%.
or go to someone else.
That is right there, bingo, perfect. The reason this shit happens is because if I, as the surgeon, minimize everything about the surgery, oh, pain minimal, recovery, you'll be back to working out in 2 weeks. How much? 3 days, you'll be back to work. And I just minimize everything. The patient's like, oh, that's not a big deal. Then they're likely to book. If I do what I do, which is your nipple can die, you can get necrosis, you can get a dehiscence. I mean, I go on and on and on. They're more likely not to book, or as you said, well, the other guy said I could be back to working out in 5 days. You said 6 weeks. Fuck that, I'm gonna go to the other guy. So they rather minimize it to the patients. And then what happens afterwards? It's too late. It's too late. You've already paid for it. Like, oops, sorry, did I tell you you couldn't go back to work in 4 days? Well, I meant 3 weeks. Like, now you're screwed and you're the patient and you have to deal with it. So 100%, you're 100% accurate on the reason why it's minimized. Other thing you mentioned to me, and again, these are what I'm so excited about this episode is that this is stuff that you're experiencing. I've heard about these things, but you're going through these ORs and you're like, oh my God, what is going on here? You refer to it as the
Wild, Wild West.
the wild, wild west of Beverly Hills, which is so accurate because it's kind of like everyone's operating room is their own private little place. No one is really checking in on them except for the handful of people that come and go. You said that there was a complication in a case, and the doctor kind of was like denying that it happened.
Yeah.
Like there was a pneumothorax, which basically means, which can happen. You're doing a breast augmentation, you're opening up a pocket, you're underneath the muscle and above the ribs, and if you inadvertently, which you shouldn't, but if you inadvertently poke through the ribs, you're going to get into the lung space. That's called a pneumothorax. You're going to drop a lung. It's not an emergency. It's an emergency. And you kind of know it. And you're telling me that happened and then the patient wasn't feeling right, or he said that it was like, no, it didn't happen. What ended up happening there?
So what happened is the patient was doing a breast augmentation. The patient had a pneumothorax in surgery, and it's kind of he said, she said, whatever. The patient in recovery was not doing well. Vitals were all over the place. We ended up sending the patient to the hospital. The patient had a pneumothorax, and the surgeon was trying to blame the anesthesiologist. The anesthesiologist, it was like a he said, she said, but it was one of those things where it happened during surgery, and I think the surgeon knew because he was being a little shady with everything. And it's one of those things that if mistakes happen, things happen. It's all about like addressing it right away, fixing it right away, not trying to cover things up, especially when it's medical. And it was just kind of one of those things where he's just like, didn't want to take any blame. It wasn't his fault. And instead of just doing the right thing and owning up to it and alerting everyone.
And I think that's a really big issue. And I think this recently, I told you about this case that happened where a patient ended up coding and they were in recovery, and the surgeon forbid the staff from calling 911 for like hours. And the person ended up being brain dead because they didn't want to alert the authorities. And so when and if a complication occurs, the key to success from a complication is the speed and the immediacy of reacting. Yeah. You have a pneumothorax, you have an MI, you have a stroke. It's all about minutes, tick, 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 tick. So what happens so commonly as a surgeon, listen, whether it was due to bad surgery or it was inadvertent, it's irrelevant at this point, right? Mm-hmm. The shit happened. You got a pneumothorax, you punctured something, the patient is, whatever the case is, the key at that point is to be like, it's irrelevant, let's figure this out. Hey, call 911, we have a problem immediately. This dilly-dallying and hoping it goes away and brushing it under the carpet and covering up your tracks, aside from being completely illegal, is wasting precious time for that patient. And this happens all the time. I can probably tell you as an expert witness, there's thousands of cases where doctors, from the minute they realized there was a problem to the minute that they finally got the patient the care they needed, was always delayed because, again, they don't want to take response. Hey, what did you do? What do you mean, what did I do? Who cares? It's done. Let's go. Let's figure it out. So I think that's incredibly, incredibly common and wrong. This here is actually something that is really common, which is patients have surgery. They're under a long anesthetic, whether it's because they had too much surgery or the anesthesia was too heavy or whatever. They get into recovery. And what are your instructions when a patient's in recovery in terms of discharging them?
You mean in general?
What is the right way of doing things and what's sort of the unspoken pressure that a nurse has? So you are a recovery nurse. The patient comes out of the operating room and you have certain responsibilities when you discharge a patient. That's what you learned in nursing school. And then there's the unspoken pressure a nurse feels that has nothing to do with nursing school, but rather the environment they're in. Mm-hmm.
So, I mean, when a patient comes to recovery, depending, of course, like how long their surgery was, if they're going to aftercare and whatnot, I mean, there's minimum criteria for patients being discharged, but of course you want to at least make sure they're awake, they can talk to you, they're drinking water, the basics, their vitals are good, they can get themselves dressed, things of that sort. So typically after surgery, we keep them for about an hour, sometimes a little bit more, just depending on how they're doing. But whenever I discharge a patient, it's when I'm comfortable with it, I can make sure the patient's safe to go home or to aftercare. There's no issues that I'm concerned about. But in a lot of these places, it's all about turnover and starting the next case and let's keep it going, let's move fast. And sometimes like they're like, this patient's been in recovery for 20 minutes. Why aren't you discharging? And they're like still asleep.
Right.
Like they're still on oxygen. They're not ready to go home. They're in pain. They're throwing up. And there's just this pressure that a lot of surgeons are just like, discharging to discharge her, get her dressed, get her out of here. And I'm like, this patient's nowhere ready to be discharged. Her vitals are like kind of crappy. Like, so it's a lot of that happening out here.
A lot, right?
A lot.
Right. I think that's actually everything we've talked about. That's not illegal yet, even though it's kind of is. It's like borderline, but that's the most common thing because time is money. And if you look at what pushes a lot of all these 90% of the stuff you've said over these 2 episodes revolves around money. If we eliminated money didn't ever get exchanged, nobody would be doing these things. It's about booking the cases, getting the cases done, doing them fast enough, saving money. It's all about cutting corners. So the reason that occurs is because you need to be back in the operating room. And while you're sitting there recovering the patient, you're wasting time. Mm-hmm. But reality is a patient, the longer the case, the more time they need in recovery. So if you do let's say a 30-minute chinog, I'm making it up, maybe that by just sheer, and you have a great anesthesiologist, maybe in 35 minutes the patient's alert, crisp, ready, they're talking to you, they're sitting up, they're in no pain, they're off the oxygen, and they're like, can I go home? But no one's gonna come out of an 8-hour marathon case. They've been under anesthetic for 8 hours, they've had a ton of fluid exchange, they have a catheter in, they're on oxygen, and they're gonna be up and ready to leave in half an hour. That ain't gonna ever happen. So for you to push the nurses, and then the nurses again are under pressure. Because if you want to be brought back, they want to know that you're an efficient nurse. Who signs off that the patient was ready to leave?
The surgeon.
Right? But it's also you're doing the charting.
And me, yeah.
So when the patient eats shit and doesn't do well and has a code, they're going to be like, so Paula, I don't understand. You discharged her. You felt she was ready? Yeah. What were your last set of vitals? Why didn't you tell me what her status was? What was her cognition? And what are you going to do then? Say, well, the surgeon told me. You have your own license. You're your own person. So again, this is happening every single day. And this one you know because how many people have complained about feeling rushed when they left?
A lot of the time, sometimes people just don't remember it too.
Their family members, their family members remember it. They're like, wait. You want me to take her home? She's like slurring her speech.
Yeah.
Why are you putting her in the car already? I heard that from our old facility, not with my patients. Well, even with my patients, because it wasn't my facility, but anytime we would hear that, we'd call and be like, hey, why are you rushing our patients out? Because when I use the facility, it's not my facility. Now I have my own facility, but then I was at the mercy of the way the facility ran it. And yes, they wanted to be efficient. So that's a really, really big issue. Another real issue is, again, I just said we're pulling out money, right? So where is one of the easiest ways to save money is in staffing. Staff. So when you have a badass anesthesiologist and an amazing tech, a phenomenal recovery or circulating nurse, it's expensive. You have some of the best staff. When you have a CRNA and your tech just graduated and your nurse literally last week was injecting Botox and now she's a recovery nurse, it's less expensive. And so you cannot compare those two environments. So I think you were saying that you notice a lot of facilities, nothing wrong with hiring a new grad, but on their own, in an island, never been trained, doing crazy cases, right?
Yeah, there's one facility I was at in particular where instead of having like 2 or 3 high quality nurses or something like that, he would hire like 15 new grads and he wouldn't provide them with any training. He would just kind of set them free. And this is also in COVID time. So this is when a lot of the nurses were just going to school all online. They've never interacted with a patient in their life, learned everything on Zoom, and now they're like administering medications, they're mixing medications, they're dealing with patients, they're starting IVs, and they have never had any patient experience. So I was at one of those places, and a lot of these nurses were either new nurses or new to the operating room, because the operating room is a whole different world than the floor is. So there was just a lot of things, like nurses would come up to me like, oh, how do you do this? I'm about to give this. And I would just be like, are you kidding me? Like just the medication errors that I would see.
So medication. So what happens when you have a young nurse or a young surgeon or a young pilot or a young is they make errors and that's how they learn, but they need to be supervised. So some of the errors you would see is medication errors. I mean, for the love of God, you push the wrong med or the wrong dose of a med, you kill a patient. Boom, right there on the spot. Oh my God, what was that? What did we just give her? Oh, that was epinephrine? We didn't ask for epinephrine. We asked for whatever. Oops.
Yeah. There was one situation in particular where I was working for a surgeon, and he was like, it was my first time with him, and he was watching me make the tumescent, which is the fluid that for the liposuction that the surgeon puts in. And he was watching me like a hawk, and it was my first day. And I was like, do you feel more comfortable making it? Like, what's wrong? And he was just like, oh, I just had a nurse here not that long ago, and she put Marcaine instead of lidocaine inside of the tumescent, which is like
game over.
Toxic.
Right.
And he was like,
stops your heart.
Yeah. And he was like, I only realized halfway through the case because I needed more, and I watched her make more, and I saw her drawing up Marcaine. And then I realized she was drawing Marcaine instead of lidocaine, and I had already put in a lot into the patient. He's like, and she didn't even realize that was a problem. She had because she was a new nurse. Right. So, the patient was transported, was in the ICU for like a week, intubated. Thank God she made it. But things like that, it's new nurses don't even know that it's a problem. Right.
It's no fault of their own, because inevitably all professions have to learn on the job. Yeah. Like I can do surgery behind my attending for so long, but at some point I have to be like, do I cut here or do I cut here? And of course, when I started 20 years ago, I probably made more errors than I make today. There's no pilot that's not better after 35 years. But you get more supervision, or you take on lesser cases, or you You know what I mean? You start at a GI lab where the stakes are lower and the patients don't get a ton of meds. You don't go start out in the cardiac ICU when you just graduated last week. There's places and escalation of experience. And so the reason they do it is it's cheaper. It's just cutting corners, and it leads to lots of errors. I think one of the things you said to me that actually was one of the like, oh, are you serious? Come on. So I've seen anesthesiologists who sit, so the anesthesiologists, in my opinion, have a really chill job, right? They sit behind the blood-brain barrier, AKA we put a drape up, and they're behind the drape. They're doing whatever they're doing. As long as the patient stays asleep and their vitals are stable, really anesthesiologists leave the room, anesthesiologists do their stocks, but really they're kind of bored. They are pilots. It's all about takeoff and all about landing. Once they get the patient to cruising altitude, it's autopilot, right? So the doctors are, bored. And I've seen, we talked about it. There's anesthesiologists, like I can't eat during a case, right? I'm starving. I can't eat. I'm physically scrubbed. You might stick a candy in my mouth or something, but I'm not going to break scrub and go. I have to break scrub to go eat. I have to leave the operating room. So I have had anesthesiologists eating full-on meals, right? You've seen
I've seen that, yeah.
Like all of a sudden you're like, is that orange? And then you pull down the thing and they're like literally peeling open an orange. Orange has that like mist that comes out. They're like, you look over there, there's like, they're having pizza. What are you doing? Leave the goddamn OR. Like, step out for a second, whatever. But you told me you saw someone vaping?
Yeah. So, the drape is up so you don't see them because we're on the other side of things. And we're in an OR. So I'm like, I just saw smoke and I was like, is something on fire? Like, what's going on? What's happening? And then the surgeon's like, he looks at me, he's like, oh, that's okay, don't worry. And I was like, what's going on?
What do you mean that's okay, don't worry?
They're
buddies. Right.
I don't even know what to say about that. But he was just behind the drapes vaping. And then I was like, what are you, I was like so shocked. I'm like, what are you doing? So when he saw I was freaking out, he went out of the OR and he went to like the recovery area, which is literally like 10 feet away.
I love that.
And starts vaping over there. And I'm like, this whole OR is like hotbox. Like, what are you doing? I was like in disbelief. Like
that's up there in one of the craziest things I've ever heard. It's like, it's like when it's if you were to have caught one of them, which has been caught before, you look over and they're shooting themselves up with propofol or some of the drugs, which unfortunately, sadly, usually almost always ends to overdose and dying of the anesthesiologist. But to be vaping, just chilling back there and just going and blowing this vape into the room while the patient's cavity is open is it was just crazy bananas. But I don't know. I actually think this other thing might be worse. You told me that there was a case where the doctor left the building.
Oh, yeah. So
wait, I just want you to understand, there might be a situation in which vaping in the OR could be trumped by something else. So what happened here?
You can't make this stuff up.
That's why I told you, I genuinely, I'm saying this from the bottom of my heart. You, and I'll do it with you, we should write a book.
We should.
We should write a book. It'll be a short paperback book. It'll be just for fun. And we'll call it OR Nightmares. Like doctors and nursing's experience or something. Because between the two of us, and I have my own stories as well, but this one I wanted you to share because when I share it, it's kind of like, oh, Dr. Rahban, you're a drama queen. Oh, you're always trying to make everything seem like, it's like coming out of your mouth, it just makes it so much better because it's like, listen, this is her experience, guys. Yeah. And this is what I witnessed. You've seen it by all these surgeons and all these amazing facilities in the best place on earth. So for you to say it is a totally different animal. So what is this final thing here? Now, what happened?
I went to interview at a facility out here in Beverly Hills, and I came to the OR, and I was obviously expecting to meet the surgeon because he's going to be working with. And his manager was showing me around the place. I was like, okay, it looks like a great place. When am I going to meet the surgeon? And he's like, oh, he's in surgery. I was like, okay, let's just go pop in there. Like, I want to see the OR too. So we go in, and I don't see the surgeon, but they're operating. And I just thought, okay, maybe it's his fellow or something. And they're doing liposuction. Mm-hmm. And the person who's doing liposuction like turns around, and me being in Beverly Hills for forever, I know a lot of the people out here. And it's a tech.
Okay, so you walk into the OR to meet the surgeon, and you're like, oh, Dr. Smith is not here. And it's like, you see their office,
Yeah.
the lipoing. The person turns around and you're like, oh, hey, Josh, the tech. And
Yeah.
right now you're like, oh, fuck.
And I looked and like everything I feel is on my face. And I was like, what are you doing? And he's like, oh, we're just doing like lipo 360 BB. I'm like, yeah, but what are you doing?
Yeah.
I was like shocked. And the OR manager saw that I was just like
freaking out.
I was freaking out. And I was like, what's going on? Like, what are you guys doing? Like, where's the doctor? Maybe scrubbed out to go to the restroom. Like, does he know that the tech is doing this?
Right.
And then he's like, oh, he just stepped out for lunch. He should be back in 10 minutes. Like, left the building, went to lunch across the street.
You're not talking about he's in the break room.
No. He left the building and went across the street to like the cafe or whatever was across the street to go have lunch. While it's just this patient went to sleep thinking, okay, I'm gonna get lipo 360 BBL by Dr. So-and-so. And there's a tech doing the whole case.
And the doctor's not even in.
He's not in the room.
Because we talked about this in episode 1. You have witnessed techs operating. I'm not talking about closing, which in and of itself is operating, but they'll like to minimize it, like, oh, it's just closing. Mm-hmm. But we talked about in this first episode that you've watched techs operate, cautery, blades. But in those instances, at least the doctor, at least the murder was done, whatever. At least they were in the goddamn OR or in their office next door or something, in the possibility that, oh, wow, is that liver on the tip of my liposuction cannon? Did I go through the ribs and enter the liver? Oh, is that spleen that I just punctured? They're there. You're telling me they're out of the building.
And it's just techs don't like they know anatomy, the basics, but they don't know to the extent of it. It's not like they went to medical school. They don't know
if there's a reason why I'm not flying an airplane.
Right. So it's just crazy to me that what if you perf bowel, you don't even know, and then you discharge this patient and then they end up dying at home. It's just madness to me.
It's madness. And it really is. The truth of the matter is all of this madness first of all, awesome that you are here and you're sharing these stories with me, because you are now corroborating what we've been trying to do with the podcast since its inception in 2019, which is bring heightened awareness to the consumer, which in surgery is the patient, that, hey, don't be frightened, don't not do it, just do it correctly. Mm-hmm. And up until now, I'm usually the only one able to say, hey, don't do this, hey, don't do that. When this happens, and I'm always the one. But since you now have clinical experience, you've actually been there yourself, you can add and highlight and expand on what I've been saying. And the ability of you to share stories outside of my arena and that of what we would consider the gold standard it's utterly frightening, shocking, and disturbing, but it still needed to be known. And the reality is that I don't even know how to advise patients, because normally we say, do your homework, right? Like that, we tried. So if I were listening to this 2 episodes, I'd be like, well, what am I supposed to do? You're telling me it's board certified surgeons, right? Yeah. You're telling me it's in Beverly Hills, right? Which means don't cut corners and don't not spend the money, right? Because, we always are like, yeah, well, she went to a strip mall. Like, what did you expect? Oh, it was $1,000. What did you expect? Oh, it was a cosmetic surgeon. What did you expect? Like, we always have a good explanation. But how do we guide these patients listening going, okay, well, how am I supposed to avoid this? I mean, like, the guy was legit. I went to the right place. I spent this money. I went to sleep. And you're telling me all these things are occurring. Genuinely, I'm asking you because I'm almost a little flabbergasted. Like, how do we avoid this? What would you tell your aunt?
I would say during your consultation with the surgeon, ask them just as many questions as they're asking you. Like, that's your time to figure out what surgeon you're going to go to. So I would ask them the questions of, do you do the whole surgery by yourself, or do you have an assistant? Do you close everything by yourself? And see how they react. Because a lot of patients don't even know that someone else that's an option. Obviously, patients think this surgeon's doing my whole surgery. So I feel like if you ask them and they get kind of caught off guard or see how their answer is, you'll be able to feel the...
Yeah, I mean, I do think that, let me ask you this as I go on to this. When you think of the collective whole of the surgeons that have done this, how many of them were, when you now think back, Dr. So-and-so did that, Dr. So-and-so did that, how many of them were you surprised, meaning you wouldn't have expected that from that doctor?
I feel like I could. I could have kind of, I guess, guessed that they would do something,
Right.
never to this extent.
No, forget about the extent.
Yeah.
But how many of the doctors that were involved in all of these egregious things, how many of them were you like, I can't believe Dr. Rahban allowed this to happen under his watch? How many of them were you like?
None of them.
None.
Yeah.
So the problem is, if, off camera, I know who the doctors are, and none of them surprised me. Like, I'm like, oh, okay, well, the things surprised me, but the fact that they were those doctors didn't surprise me. But the problem is the patients don't know that, because their patient-facing persona is cleaner than what you and I know them. And what I'm struggling with is I always want to leave patients when they leave an episode with a tool. Like, if you want to avoid X, then this is what you should do. And then they go home with that. And these 2 episodes are so frightening. And I want to know what to tell them so that they can avoid this. The reason why having you on was so critical is because you're talking about the best of the best in far as they're concerned. So I do think what Paula said is probably right, which is, let me see if I could distill it for you. When you do your consults, not your Instagram consult, not your TikTok consult, not all the influencer consults, not all the bullshit that I could pay for, but when you actually meet the doctor and you spend more than 5 minutes with them, so your consult should be 45 minutes, you should be long. So why? You're about to go on a speed date, you're going to go out to coffee with someone, and then you're going to marry them. So if I'm going to marry Paula and we're going to meet for coffee, I'm going to try to spend as much time as I can with Paula, because this is the only time I'm going to figure out Paula, right? Paula's going to be my wife, Paula's going to have my kids, Paula's going to make the difference in my life. So I'm not going to meet Paula for 5 minutes and ask her some bullshit ass questions and then marry her. I'm going to ask, are you a Republican? Are you a Democrat? What's your thought process on money? Where's your religious, right? I'm going to ask some very hard questions because I only got this speed date to figure this out. So number one, I think what Paula said was right. When you go to the actual consult, make sure it's a long consult. Make sure you bombard them with these questions. Do you ever leave the operating room? Do you close everything yourself? Do you have anyone in the room besides you that actually does any part of the surgery, any of that stuff? Mm-hmm. Does your tech ask them directly? Does your tech close? Who's your anesthesiologist and how long have you known them? How many cases have you done with this anesthesiologist? Are your nurses new grads, or are they, like, all the things we said to you, ask them, because she's right. You'll catch them off guard. They'll usually not answer in a way that I think you'll be like, oh, that was authentic. Oh, that seemed like they were telling the truth. Mm-hmm. And I think if you ask enough of them, you'll catch them in their lie. Because otherwise, I think that just going to, board certified plastic surgeon in Beverly Hills who's got a lot of followers and tons of reviews doesn't mean shit. It really doesn't. And sadly, this is just one of those things that you got to have a gut. But I think that the reason why I asked her that is because I do think if you knew these surgeons like we know them, you wouldn't have even questioned it. You wouldn't have been like, you would have not, I think she said, I'd be shocked at the extent of it, but none of the people she mentioned to me, I was like, what? Really? So-and-so did that? Because that's who they are. They're all kind of like, hey ho, slickster, Beverly Hills plastic surgeon, driving fast cars and, hooking up with their managers. It's just that environment. And usually things of this nature occur in those environments. At any rate, we're so grateful, for you now being on board with our team. Hopefully you equally feel the love affair in that you will not have any further such stories.
I'm very glad.
Sadly, you will not have any more of this drama.
I hear about it from other nurses all the time, though.
Right, yeah. So that will add to our book.
Yeah.
I think we'll have an edition 1, 2, and 3 perhaps. Secondly, we're grateful that you're willing to share these stories. Not everybody wants to come and talk about these things. This is where we talk about taking a stand, having some courage, speaking up against what's wrongdoing. And now that you are, in a safer environment, it's great that you're having this conversation, because you could have just kind of like, I don't really want to talk about it. I'll just, it is what it is. But I don't think you would have, you can help a lot more people by sharing it. So thank you for sharing it. And I'm sure we'll have more episodes about this because you'll eventually accumulate some more stories and we'll have you on. We'll definitely have you on because I want to have you help us talk about, now that we talked about all these disasters, I'd like you and me to talk about what is the right way so that if you guys are going to go have surgery, you're like, wait, so what should it look like? And then we're going to delineate for you step 1, step 2, step 3, so that if you're somewhere and you're having surgery and it's not following this route, you know something's fishy, okay? Well, that's another wrap for Plastic Surgery Uncensored. I hope you enjoyed our 2-part series as much as I did. As always, we ask 2 parting requests. Number 1, go write us a really fantastic, spectacular review. And secondly, share this episode or the episodes and the show in general with people you love, because you never know who's gonna go have surgery and they're gonna wanna have had this episodes loaded and listened to. All right, guys, that's a wrap. I'll see you next week on Plastic Surgery Uncensored.